Psoriatic arthritis is a chronic autoimmune disease characterized by inflammation of the joints and skin. It is associated with psoriasis, a skin condition that causes red, scaly patches, and may involve various systems in the body. Here's a detailed overview. Key features: joint involvement, pain, swelling, and stiffness in one or multiple joints, affects fingers, toes, wrists, knees, ankles, and sometimes the spine. Spondylitis, sausage-like swelling of fingers or toes, is common. Skin symptoms: psoriasis plaques, red patches covered with silvery scales, commonly on the scalp, elbows, knees, or lower back. Severity of skin symptoms varies and doesn't always correlate with joint symptoms. Nail changes, pitting, thickening, or separation of nails from the nail bed, the hair falling, for instance, from the nail bed. Sinusitis, inflammation at the sites where tendons or ligaments attach to bones. Heel or sole of the foot, causes and risk factors. Immune system. Immune system is part. An overactive immune system mistakenly attacks healthy tissues, causing inflammation. Genetics. Family history of psoriasis, or PSA, increases risk. Environmental triggers. Infections, stress, or physical trauma may trigger the disease in predisposed individuals. It commonly develops between 30 and 60 years old, but can occur at any age. Psoriasis. About 30% of people with psoriasis develop PSA. Types of psoriatic arthritis. Symmetric PSA affects joints on both sides of the body, similar to rheumatoid arthritis. Asymmetric PSA. Asymmetric PSA affects joints on one side, often milder. Distal interphalangeal predominant. Distant affects small joints in fingers and toes. Spondylitis involves the spine and sacroiliac joints. Arthritis mutilans, severe deforming arthritis. RR. Symptoms: joint pain and stiffness. Joint pain and stiffness, worse in the morning or after inactivity. Fatigue, reduced range of motion. Skin and nail symptoms: eye inflammation. Uveitis. Full diagnosis. Medical history. Evaluation of joint pain, skin/nail issues, and family history. Physical examination. Assessment of swollen, tender joints, skin, and nails. Imaging tests. X-rays, MRIs, or ultrasounds to detect joint damage. Laboratory tests. No definitive blood test for PSA. Tests to rule out other conditions. Rheumatoid factor, RF, and anti-CCP, negative in PSA. Elevated inflammatory markers, CRP, ESR. Treatment. Medications. Relieve pain and reduce inflammation. Relieve pain and reduce inflammation. Disease-modifying anti-rheumatic drugs. Slow disease progression. F. Methotrexate, sulfasalazine. Biologics. Target specific parts of the immune system. TNF inhibitors. IL-17 inhibitors. TNF patients with IL-17 inhibitors. Corticosteroids, short-term relief of inflammation. Lifestyle modifications. regular exercise to maintain joint mobility, healthy diet to reduce inflammation and manage weight, stress management to reduce flare-ups, physical therapy helps improve joint function and reduce stiffness.